Hello, hello. Welcome. There we go. The first person is loaded in. Wonderful. Welcome, everyone, as you're slowly virtually filing into the room, if we can call it that. Welcome to today's education session. Today we are learning about trauma and cancer. Before we get into the meat of the presentation, we're just going to go over a little bit of housekeeping, so please bear with me. My name is Gloria Lausch. I'm the virtual program coordinator here at Gilda's Toronto. And I'm going to be behind the scenes, not beside them, throughout this whole presentation. So for any tech, social, whatever commentary issues you want to direct to me, I'm your gal. You can reach me through the chat box or the Q&A box. So two buttons that I really need you to know about. At the bottom of your Zoom screen, it's either one chat bubble or two chat bubbles. Whichever one your eyes lay on first is the one that we want you to use. If you don't see either of them, you may have to press the three dots that say more, and then chat or Q&A will come up through there. If you're on a tablet or a phone, you gotta swipe left, right, up, down. I'm not really sure which one. They're all so different, but swiping one way or another is going to get you to either of those two buttons. So at any point throughout this presentation, if you have any questions for our wonderful presenter today or comments that you would like to direct to him, use one of those two buttons, whichever one you find. As soon as a thought pops into your brain, please throw it into the Q&A or the chat box. We will be reading out your questions and your comments throughout the presentation. And if we don't get to it right away, there will also be some extra time shaved off at the end just to make sure we don't miss anybody. So fret not if we don't get to you right away, but still, once it's in your brain, pop it into either of those two buttons. This webinar is being recorded, so everything that you see here, touch, smell on the screen today, you will be receiving in a neat little YouTube link. And it's a webinar. We can't see you, we can't hear you, so it is really important that you use either of those two buttons to communicate with us today. I'm going a little out of order today. This is not usual, sorry. Finally, I want to let you know about program@gildasclubtoronto.org. If you have any questions, you're looking for any resources, whatever it may be, please send us an email to that email address. Somebody is always monitoring that inbox. It's the best way to get in touch with us. Even if you're not a member yourself, still the place to go. All right, finally, who's taking us through this next hour? We've got the wonderful Jon Hunter today. So Dr. Jon Hunter is a professor at the University of Toronto and holds the Pencer Family Chair in Applied General Psychiatry at the Sinai Health System, where he also heads the Psychosocial Team at the Marvelle Koffler Breast Center and works on the Psychiatric Consultation-Liaison team. His interests include the psychological care of cancer patients, the role of early life experience in adaptation to disease, the role of therapeutic alliance in treatment outcomes, and supporting hospital staff in times of strain. Without further ado, Dr. Jon Hunter, show's yours.
Thank you very much, Gloria. Let's get the screen up. Is that working?
It is, but I can see your next slide and your notes.
Oh, I'm going to do that now. Oh, you're not seeing, maybe if I, well, that's distracting, eh?
No, it's still the same. What's going
Still
on?
the same.
Sorry, folks. Hang on 2 seconds.
What's that?
We're just seeing the PowerPoint page. So including this, all the slides on the left-hand side.
Yeah. So I tell you what the difficulty is. Difficulty is I have two monitors and it's showing the way I want it to on one monitor, but that's not the Zoom monitor.
Aha, okay, so when
Oh,
you go to share, so stop sharing.
yeah. Stop sharing.
Yeah,
Okay.
we'll start again. So when you press share, you should be able to choose the second screen too. Okay, so I see Zoom now.
Yeah, I think that's actually I think I need Zoom one,
Okay.
screen one.
Oh, perfect. There we go.
That working?
Awesome.
Okay. Well, that was a trip, guys. Sorry for that. There seems to be always a little bit of a wrinkle in these things. Good to continue then. Gloria, are we
Yes.
okay to just go ahead?
Yes, perfect.
Okay. Thanks, guys. Sorry for the little glitch there, but let's carry on. Advance the slides. That'd be good. Okay. Here's the plan for the day. We're going to talk first of all about how trauma or adversity is related to cancer. And then we're going to talk about the inverse, how cancer can be related to trauma. In order to do that, we're going to cover two topics: trauma in society as we understand it these days, and what the illness outcomes are that are attributable to adversity and trauma. And if you want, we can carry on to talking about attachment, which is a psychological behavioral system that is related to hardship and development and which expands the idea of trauma and adversity a little bit in terms of disease causation. I'll be asking for feedback when we get to the kind of halfway point there about whether you guys want to pursue that or whether you want to stick with the pure trauma stuff. At which time we'll just talk about questions if that's what you prefer. I put a warning in here because we can't talk about trauma without referring down happy things. I'm not going to be referring to things in a great deal of detail, but there are going to be some definitions which could be triggering for folks, and I think it's important that you each do what you need to do to look after your own well-being. So when we talk about trauma and its potential impact on cancer development, what we really functionally are talking about in terms of evidence is the Adverse Childhood Experiences Study, which was started years ago by Vincent Folletti and Robert Anda. What they did was they looked at a survey of people in a large HMO in the United States, and they asked them whether they had any of these adverse childhood experiences, which you can see on the left. These were not subtle uh, inquiries. These were asking about whether you've been hit, whether you've been sexually abused, whether you've been sworn at or insulted. You can see a list on the left, not great things. And people answered yes or no. And if they answered yes, they got a score of one. So if you take physical abuse, an adult in your home often pushed, grabbed, shoved, slapped, or threw something at you, or ever hit you so hard that you had marks or were injured. If you answered yes to that question, you got a score of one. If it happened to you once, it was one. If it happened to you every day for 5 years, it was still just a one. So we understand that the score, the ACE score, is by and large likely an underrepresentation of tough things that happened to kids. When they did that uh, uh, survey of people, and they looked at how often it occurred, and what they were staggered to find out was that 60% of the population had at least one of these adversity things that have happened to them. Only 40% of the population, excuse me, only 40% of the population did not have adversity in their childhood. So that's the first take home, is that it is the case that in North America, people grow up having had some reasonably crappy things happen to them when they were kids. This is the Canadian data that was surveyed by Tracy Afifi in Winnipeg a number of years ago. And what she was able to determine was that fully 30% of the Canadian population experienced adversity or intimate partner violence as experienced adversity in the youth, as a youth, or had intimate partner virus. I'm sorry, guys, I'm recovering from the GI flu and just came in to do this, and I'm a little inarticulate. My apologies. About a third of Canadians have had adversity. They then looked at the adversity scores and looked at the adult experience of illness. And what they found out was that adversity in childhood was linked to adult physical illness. In fact, it was linked to a lot of adult physical illnesses. And you can see the diseases that have been found to be associated with adversity in childhood here. And it's frankly just about every disease that they looked at has been linked to adversity in childhood in what is called a dose response curve. What that means is that if you look at no adversity, there's a risk of disease that is, let's say, X. And then as you look at one adversity, X goes up. If you look at two adversity, X goes up further. If you look at three adversities, X goes up even further. So the degree of adversity incurs ever increasing risk to physical illness, such that we can draw a graph like this, and I'm going to highlight the cancer part for you, which suggests that about a quarter of cancer risk can be linked to adversity in childhood. You can see that it's also linked to things like cardiovascular disease. It's linked to alcoholism, large risk to anxiety. But for our purposes, we'll just identify that fully a quarter of the risk of cancer as an adult can be linked epidemiologically to adversity in childhood. Here's that dose response curve that I was showing you. I'm afraid the numbers didn't translate on the slide. What this shows along the x-axis is the number of adversities in childhood. So this is 0, 1, 2, 3, 4, more than 4. And what this would be up here is the likelihood that the person is smoking. And what you can see is that as you get more adversity along the x-axis, you get more likelihood that the person will be a smoker. So that gives you a nice illustration of the dose response curve. It also gives you a nice illustration of how it could be that adversity is linked to cancer risk, because obviously smoking is linked to cancer risk. We all know that. So that if you have adversity linked to more smoking, then more adversity is inevitably going to be linked to more cancer risk. Okay, so what we have here is a model that suggests that this epidemiological finding that more adversity in childhood is linked to more cancer may well be because of intervening factors like more exposure to smoking, for instance. In fact, myself and a colleague, Bob Monder, have suggested that childhood adversity can be thought of as a cause of causes, because it is linked to health risk behavior. It is also linked to physiological changes, in particular the way your body responds to stress. So that people with childhood adversity can have an exaggerated stress response syndrome, which is not great for physiology and increases wear and tear on the body. It's also the case that it's linked to social determinants of health. These are things like poverty, lower levels of education. So if you have more adversity in childhood, you're more likely to be impoverished. You're less likely to have higher education. You're also more likely to be struggling a little bit with interpersonal relationships. That's the attachment piece that I can elaborate on in a second if you want. And it does, in fact, make you more susceptible to things like depression and anxiety. So when you put all those things together, childhood adversity is linked to an increased likelihood of physical illness, an increased likelihood of mental illness, and troubling interactions with the healthcare system, meaning that people with higher adversity trust less so that they're less likely to feel like they can uh, go along with what a doctor says without challenging it or being terribly scared. They're less capable, by and large, of expressing themselves really clearly. They're less capable, by and large, of straightforward self-assertion. So all these things lead to interactions with the healthcare system being pretty problematic. So that's how that's how trauma and adversity in childhood can relate to um, cancer development in adulthood. Now we're going to flip it over on itself and talk about the relationship between how cancer in adulthood can cause trauma. And to do that, I'm going to give you an illustrative example. This is a sheet of paper. Some of you may, by hard experience, recognize it. If you get a blood product in your healthcare, Canadian Blood Services sends you a sheet of paper after the fact saying, just so you know, you got this blood product. Okay, this came up way back in the HIV era as a way to enable patients to track their own exposure to blood products. So this is a patient who got a notification thanks to their cancer treatment. They needed some blood products. They got 2 units of albumin. And afterwards, which is a protein found in blood, afterwards they got this notification. It didn't trouble them at all. It felt like the system was actually looking out for them. And then they had an event where they got this notification. So you can see the huge number of blood products they got. Um, that indicated that was a consequence of them having had a very serious bleed from their stomach as a result of their cancer, such that they had to go to the intensive care unit. They had multiple units of blood to prevent them from bleeding out. They had very extensive interventions during that time. They were delirious and remember it as a very frightening, scary event during which they misinterpreted some circumstances in a scary way, in a paranoid way. Not surprisingly, because they couldn't understand what was going on because they were um, so physiologically challenged by being um, so sick. Thereafter, they recovered. The ICU saved their lives and got them back on their feet. But thereafter, they became really quite anxious about further health care. They became quite anxious about returning to the hospital. And they had what shrinks call a stress response syndrome. And I've given you a screen here that shows you um, the 9 experiences that people can have after events that stress them out enough that they're left with a psychological response. And I've highlighted and bolded the first 5 because these are the ones that we see clinically most often after this kind of thing. And I'll just go through them one by one to elaborate on them for you a little bit. Again, I'm hoping that these aren't triggering for people, but maybe validating for your own experience of what's happened. The first is fear of repetition, which is just what it sounds like. It is that this terrible thing that has happened can happen again. The blood loss example I gave you is a dramatic one. But people, for instance, who come in for a screening mammogram and get a diagnosis of breast cancer will fear with their next mammogram that they're going to get bad news again, right? It's pretty straightforward, pretty easy to understand, but it can lead to people being avoidant and not wanting to come in for a subsequent mammogram when that's an important part of their care. Fear of merger with victims is a bit of psychobabble, but is actually straightforward. Idea it is that if you've been going through chemotherapy on the same schedule as somebody else, and you get a kind of a chemo buddy, that you see in the clinic each time, and something untoward happens to them, you might fear that the same thing can happen to you. If Mary had a disease recurrence, well, maybe you're going to get a disease recurrence too. Even though you and Mary may have a similar kind of cancer, there's nothing that predicts that what happened to her will happen to you. But that's the way people's minds work. They tend to blur those margins and see those things as occurring together. People, particularly people that kind of pride themselves about being tough nuts, about being able to look after themselves and being relatively invulnerable, can have psychological reactions to the vulnerability they feel about the disease or the vulnerability that treatment creates, for instance, by causing significant fatigue or dependency. And that emotional reaction might be feeling ashamed they have to count on other people, or being furious that this has happened to them, and then being angry at themselves, at the people around them, sometimes at the healthcare team. You've probably heard the expression survivor guilt. That's another thing that can happen is that people go through treatment. I'll use the chemo buddy example again. They have somebody that they're going through treatment with, and that person gets recurrent disease and they don't get recurrent disease. But at that point, they can think, why me, in the sense of why have I had a good thing happen? I once saw a patient who was was one of two sisters that had cancer, and she was the older sister, and got cancer postmenopausally when her children were grown up. And her younger sister also got cancer premenopausally when her children were younger and had a more difficult time with it. And the older sister couldn't help but experience this as uh, I feel guilty about having a good outcome because I would like to give my good outcome to my younger sister whose children are younger, and it feels wrong for me to have this good outcome. And of course, straightforwardly, just sadness. When tough things happen, people feel sad about it, particularly if it results in an explicit loss, like loss of a person or loss of a job, or less explicit losses, but nevertheless significant losses, like potential things you hope to have in your life, like the chance to have a child or the chance to develop a career, or those kinds of things that you were looking forward to. Those are losses that can sometimes be a bit hard to articulate, but that cancer can precipitate as well. Here's the good news, having told you all this stuff, which I think we have to agree is challenging, difficult news. The good news is this. The calmest reaction to adversity in childhood or to a traumatic medical event is being okay. Most people, most of the time, have these difficult things that happen in their life, and they recover. They might have a bad time. They might have a fairly narrow band of things that they avoid or don't like. But most of the time, they shake it off, they carry on, they have a life not so different than what they would have had without it. And occasionally we'll give credit to that adversity for developing an aspect of their personality or their coping strategies that they see in a positive way. The other good news is that most reactions, if we're thinking of the avoidance of mammography example, most of these reactions fade with time and with normal, if you will, follow-up appointments. In other words, if you have a bad news mammogram, then the first mammogram after that is tough. But as time goes on, you have 2 or 3 normal follow-ups without bad news attached to them. Your attention tends to reduce. You tend to get used to it. And you might have a bad night the night before, but not in fact have that tough a time with it. And people learn how to do things to help themselves out. They maybe take a sleeping pill the night before the follow-up, or they make sure they have a sister or a spouse come with them to the follow-up appointment, that kind of thing. And that moderates their effects. For those people that have ongoing difficulty and feel panic or depression or stress and insomnia, treatment helps. Treatment might be medication, like I said, a sleeping pill the night before, or occasionally more long-term medication like an antidepressant to help with panic or sadness, or psychotherapy. And psychotherapy, as you may well realize, takes many forms. It can be quite a straightforward intervention that you can go through with a psychotherapist or that you can learn online that has to do with mindfulness or breathing exercises, the kind of thing you might get from an app like Calm or Headspace, or more personally directed, reflective psychotherapy, where you spend some time talking with somebody about how this event fits into your life, how it affects your sense of yourself, how it narrows some of your uh, life choices, and how it maybe expands some other life choices for you. And people benefit from that kind of talking it through psychological, relational psychotherapy. So that's the good news. This is not something that any of us have much of a choice about. We are exposed to adversity either developmentally or in terms of illness because of our life course. But in addition to most people recovering on their own, there is psychological treatment that is of benefit to folks. Now I'm going to take a break here. Maybe, Gloria, we could review the questions. Let me just ask you all to uh, give me feedback. There's another piece I have slides about that's about the attachment system. The attachment system is a developmental system, a psychological behavioral system that we all develop in the course of our childhood that gives us some propensity to react in certain ways to stressful things. It doesn't just address trauma and adversity per se, but trauma and adversity can affect the way our attachment style develops. And then we have some information about the way attachment style can then impact on some cancer experience. So it's kind of next door to the trauma idea. And I can expand on that if people want me to, or we can stick with questions you have specifically about trauma and adversity. When I've done this talk for Gilda's in the past, there was sometimes quite a lively dialogue. So I want to make sure we have enough time to do that and not cut anybody off. So over to you, Gloria. We can respond to some trauma questions now, or you can give me feedback about whether you want to go ahead with the attachment piece.
Thank you. Let's see. I am happy to learn a little more about attachment. few people interested in the attachment. No questions in particular, though, but it looks like
Oh,
people are interested in the attachment system.
okay. Well, I'll take that as go for attachment, Hunter, and swing on into it, guys. Again, feel free to generate questions as we go through this, and we should still have some time at the end for some information about that. Okay, am I back over here? Yeah. Okay, so the attachment system is something that has been confirmed by experiments and observation. It's not somebody's smart idea. It's a uh, proven fact that mammal infants develop um, uh, an attachment style over the experience of um, being babies. The issue here, guys, just to put in broad perspective, is that humans have benefited tremendously in evolution by having big brains. Big brains means we can figure stuff out and we can develop culture, and we can use tools, and we can remember things are enormously evolutionarily advantageous. But big brains also means a big head. And if you have too big a head, you can't get through the birth canal. So what evolution did to solve that problem was deliver the baby before the brain is fully developed. So all primate babies, most mammal babies, and certainly human babies are delivered before their head is fully developed because we've got to get them out of the womb. Being an undeveloped brain, though, it needs to be looked after. And the way parents look after babies is called bonding. You've heard that expression. That's the way we as parents develop this overarching need to be protective of our children. And the inborn mechanism for children is the attachment system. And the attachment system has two basic rules. One is stay close until it's safe. Hold on to your mom. It's typically a mom, but it could be anybody who functions as a mom. It's really a role as opposed to a biological state. It's a parenting role. Stay close until it's safe. And then when it's safe, please go and explore the world until it feels dangerous. And then come on back. Okay. Now, the way this was explained by John Bowlby, who's kind of the uh, foundational person in the world who established the attachment theory as relevant to human beings, was with an analogy to a barking dog. I'm going to take you through Bowlby's analogy quickly here. What we have here is a mom who is a safe haven for a child, and we have a child on their own, and in between them we have a barking dog. And what that's supposed to elicit for you is a scary state. This child is scared by the dog and has to figure out what to do to feel safe again. And there are a couple of choices. If we were in person, I would ask you to articulate the choices. I'm gonna say them out loud because it's too clumsy to do over the Zoom. But think what you might do in this circumstance. If you're a child and there's a barking dog between you and your mom, what might you do? Well, one thing you might do is run around the dog to get to your mom. And Bowlby would say that's a perfectly good strategy of a secure child. Why is it a secure child? It's a secure child because it believes that it's got the capacity to make that trip, and its mother will be able to take care of it when it gets there. So it has a positive view of its mother, and it has a positive view of itself. The other thing it might do is hunker down a little bit and wave or cry for the mom. Same thing. That is a potentially, is a child understood to be essentially secure. Why? Because it believes that mom will come if it calls, and it believes it's okay for a moment. if in fact it calls out. So those are two secure strategies that a baby might employ that suggest that it has a positive sense of its own capacity and trust in the mom that they can respond. Another thing the baby might do is overcome by fear, just bolt in the opposite direction and go away from the dog. That's understood to be an insecure strategy because although it might be increasing safety by getting away from the dog, it's also getting farther away from the mom. And that can lead um, to the child being in less secure circumstances. Essentially, that child is betting more on itself than on the mom, right? Because it's saying, I'll be better off on my own way over here, even if it takes me farther from the mom. The second last strategy is the baby can run past the dog to the mom. This is a baby who's betting more on a mom than on itself. It just can't tolerate being by itself. It has to get close to mom. And again, that is something that might work out okay, but it's taking you actually closer to danger before it gets you out of danger. So it might be a bit of a problem. Okay, so those are the four basic strategies. And then there's one more, which is a distressing one to talk about. And that is the child for whom the mother and the barking dog are the same. A mother who is both what the attachment system tells you is the person you're supposed to go to for succor and support, but has been scary or harmful enough to you that they're also a challenging person to connect with. And those kids have a disorganized style of attachment, meaning they can't solve that problem. They don't know what to do. And they might run towards the mom and then away from the mom, run towards the mom and then away from the mom. Or they might fall to the ground and kind of curl up. They just don't know what to do. So when we look at the way those attachment styles in children translate into adulthood, we see that a little more than half the population is secure. Again, let's recognize that this is not pathology. This is not a type of psychological illness. These are normal variants in the population. 55% are secure. 20% are that anxious, gotta run to mom type. We call those also, another label for those is compulsively care seeking. They feel driven to seek care. The ones that would run away from the dog are compulsively self-reliant. They're going to go look after themselves. And a minority of the population, 10%, are disorganized or are so scared they don't know what to do. This is a complicated slide, I guess, but you can look at it afterwards to really get into it. What it's meant to convey is that if you have secure attachment, you have a bunch of associated capacities that are really helpful to you when you're trying to deal with illness. You do well with social support, for instance. You report your illness clearly so that people understand what you're talking about. You can utilize healthcare relationships well. You're less likely to have an addiction. You're better at communicating what's going on. Your stress response is fitting for the stressful circumstance. It's just an advantage, not just around illness development, but in coping with illness once you have it. And we have a little bit of data to support this. So when we look at oncology, cancer medicine, and attachment, we find that the fearful folks have the poorest adaptation of breast cancer. In the same way they're disorganized around their fear response and knowing what to do, they're kind of disorganized around taking care of themselves. And they're particularly at risk for delayed presentation because they don't trust that it's going to be okay to go to a doctor. They don't trust themselves in judging when it's necessary to seek help. And so they tend to show up later than they should have with whatever their cancer symptom is. And then they have trouble negotiating our relationship with the team. In advanced cancer, we see the securely attached folks have the least amount of distress and do well with social support, whereas the insecurely attached individuals feel less emotional support and as a result have more distressing emotion that they have a harder time dealing with. And they're more likely to be referred to people like me that work in psychiatry in cancer, which is great. We're happy to see them so we can try to provide them with some care. Interestingly, there's also a link here to the caregivers of people that have advanced cancer. Braun showed years ago that in the caregivers of people with advanced cancer, if they have an insecure attachment style, they're going to feel more depressed. And if they're anxious, if they're the compulsive care seeking type, they may actually kind of get in the way of the person who has cancer by intruding with the need to administer care. In other words, they're not administering care based on what the cancer patient themselves asks for or needs, but because of their own need to be present in the caregiving circumstance. Whereas with the dismissing uh, uh, insecurely attached individual, again, they're driven by their own need to not feel too much distress and to pull away a little bit. So they may not be as available for care of the person that has cancer as the person with the secure attachment style would. This is a bit of a difficult graph. Suffice to say that what it demonstrates is that insecure attachment in cancer patients translates into more depressive symptoms as well. Okay, so I'm going to wind it up now, leaving you with a couple of where can you go if you want more information stuff. This is something we call the self-assessment kiosk. This is the web page where you can access it. This is a completely anonymous source of psychological measures. If you go to it, you are given the opportunity to measure your own level of depression or anxiety or childhood adversity or attachment style, which is called relationship style here. You will be asked if you want to participate in a research study. That's still highly anonymous. All it means is that the researcher, who's a colleague of mine, can get a look at your pooled data with everybody else who's put data on the web page, which is several thousand people at this point in time. It in no way identifies you, but you don't have to agree to be in the research to do the measures. You can do them yourself, just to understand where you stand, because the results come out. They give you a little bit of feedback. So if you did the childhood adversity, for instance, and you had a score of 2, it would say your A score is 2. This is consistent with 25% of the population and is associated with some people having higher than expected risk of illness, something like that. It just gives you a sense or two to help you understand what that result means. The other thing are the Men in Plaid videos. If you search Maunder and attachment in YouTube, there's a series of videos, a couple of screenshots here. This young buck over here is me, and this is my colleague Bob Maunder. And we put together, originally for psych residents, but available to everybody, a series of 5-10-minute videos that relate this stuff that I was talking about attachment, in a bit more depth and are accessible to you anytime you want to see them. They've had, I don't know, 20, 30,000 views, so you can go to that and see if it clarifies a question for you. And lastly, Bob and I have written a number of books that if you want to, you can get, which I guess is a conflict because it feels now like I'm selling a book, but believe me, we don't make any money on it. So I'm not really actually benefiting from this. The first one we wrote was Love, Fear, and Health, which is a demonstration of how the attachment story shapes health and healthcare. Um, this one here, A Guide for Primary Care Practitioners, is more for physicians. Damaged is the latest book and focuses in on childhood trauma and adult illness. It's a bit of a tough read. It's essentially a case study on one person who had really awful adversity in their childhood and then later adult illness and how those two things fit together. But for those of you that want to get into the nitty-gritty of it, that describes it pretty effectively. And in the next year or so, we're coming out with a book about coping more generically, not just about trauma, but in life in general. So, 12, 13, 14 minutes left. I think I will stop sharing the screen and be happy to address anything in the chat or any questions anybody has.
Thank you so much. This has been really wonderfully informative. And I think maybe we were worried with some of these topics. It feels a bit inaccessible. They're like very jargony and you won't understand, but this has been very understandable. So thank you very much.
Glad to hear it.
We don't have any questions, so I will remind everyone, two buttons, whichever one you find first, Q&A or chat box. Please pop your questions, comments, if anything resonated with you, anything that you want to share into either of those two buttons. We'll give it a few seconds while people are typing away. If people are interested in those books, where can they find them?
Um, they're sold by U of T Press. I think they're all on like Amazon. Most of us aren't buying American things at the moment. So you can go to Indigo or order through your local bookstore because they're sold through U of T Press.
Wonderful. Thank you. Thank you. Oh, a question here. Would attachment styles, I guess, change over time? For example, if someone was secure at 2 years old, can you become insecure later in life?
Oh, well, that's a great question. Here goes. It's the answer. The answer is a little complicated. Here goes. Stay with me. If you look at studies where people did precisely that, they did attachment subtyping of kids as young as 18 months. There's a way you can do that that's pretty reliable. And they followed them out to like age 35. It turns out that in one study, almost everybody stayed the same. Fully 75% of people had the same attachment style from when they were 18 months to when they were 35, which, if you think about it, is friggin' amazing, right? Think of all the relationships that go on in their life, and it stayed the same. There's a second study where only about 30% of people stayed the same. So, same methodology. Why are the two studies not showing the same figure? And the answer turns out to be distressingly predictable and very pertinent to today's topic. The people that stayed the same were from Connecticut. High SES group, high social economic status. These were essentially middle class families that were well resourced. And so they got through life without a lot of hardship. The second group were racialized single moms in a poor neighborhood in St. Paul, Minnesota. And they were without much in the way of resource. And the kids growing up in those circumstances tended to have quite difficult things happen to them. And so the secure people at 2 years changed over time. Now, what's interesting is they didn't change just any old way. What happened was they had tough things happen to them and they became more self-reliant. It's like they said to themselves, oh, life isn't so great. I better learn to look after myself. And they became kind of independent, self-reliant. I'm not going to depend on anybody kind of folks. So that's the change that security typically goes to. There are two other changes in terms of longitudinal studies that are worth knowing about. One is people that are anxiously attached, the kind of clingy, preoccupied, worried folks, can over time become more secure, which is great news. And we don't know, we think that's because they tag into a good relationship. That because they're kind of clingy, they get connected to somebody. And over time, that person is solid enough and secure enough and reliable enough that in fact they confer security and the person's style modifies to trust this new relationship and it takes precedent over what happened to them when they were kids. The last piece of data, giving you the whole 9 yards here, the last piece of data is that if you look at the geriatric population, if you look at people over the age of 70, it turns out that there's only two attachment styles left. There are people with security and there are people that are dismissive. And that's because the anxious people have either died or they've developed that secure pattern that I described. They've connected to somebody who's doing okay. And the secure people have either stayed secure or become dismissing. Dismissing people just stay dismissing. So if you go out long enough, you end up with secure and dismissing as the two styles that are left.
That's pretty cool. Really interesting. Thank you for that explanation. Another question here. Do you think that assessing for ACEs should be done for mental health professionals supporting individuals with a current cancer diagnosis?
Yeah, that's interesting and I think quite a nuanced question, to tell you the truth. ACEs, you understand, what I'm giving you here is epidemiological data. It tells us nothing about any individual, right? The commonest response to these adversities is people doing okay. So just because somebody has an ACE score does not predict that they're going to have difficulty. And the group that I work has the following kind of two minds response to this question. The first is all therapy should be trauma informed. We should basically practice what are called universal precautions. You can't always know if somebody's had trauma. Even if you ask, they may not want to tell you, particularly on a first encounter. Why the hell should they trust you with that kind of information? And so you should be delivering care that if it is being delivered to a person whose life has been affected by trauma is not provocative or difficult for that person to receive. So we sort of assume the trauma. That means, on the other hand, that we don't need to ask something like an ACE questionnaire. And we believe a lot in the healthcare relationship between the patient and the doctor and letting it develop in a personalized kind of way. And we're not so sure that leading off with a questionnaire like ACE, some people would administer it before they even met the patient. It's something you do before you get to the clinic. We think that's a bit kind of challenging for this relationship to develop. Whereas we find if you've had a session or two with a patient and you've developed a therapeutic alliance and it feels like a trusting thing, you might be able to say, there's a questionnaire that helps us kind of just grade how these things go, and it might be useful to you. And we'll send them to the kiosk. And that way they can do the ACE questionnaire for themselves. You can also save the results of the kiosk as a PDF. You can hold on to it for yourself. And if you want to give it to your therapist, you can then forward to it to your therapist. So we like to do it in that kind of patient regulated kind of way, as opposed to just kind of willy-nilly giving it to everybody, even though we kind of assume everybody's got it.
Makes sense. Thank you. And final question, we'll wrap up here. Are highly sensitive people more at risk of developing insecure attachment? And then a little example they give is as the parents may treat all of their children the same, but the sensitive one would filter the treatment more negatively.
Oh, what a great question, and a complicated question. Again, I'm afraid I would refer you, um, if you want to read more about this, on a distinction that the developmental psychologists have between dandelions and orchids, which may be language uh, that Gloria is familiar with. It comes from, I think, a Dutch expression of how some kids are. The metaphor is this, that dandelions can grow anywhere and they'll be okay. They'll do better in a garden than they will on the edge of a sidewalk, but they'll do okay anywhere. That's most kids, right? They'll be all right, even if they don't have the greatest parenting, they'll be fine. But some kids are orchids, and orchids really blossom when they get just the right humidity and just the right nutrition and just the right fertilization. In a garden, they won't do quite as well, but they'll do okay. And if they're in the gravel on the edge of a driveway, they don't do well at all. So there is an interaction between the kind of sensitivity of a child, the environment of rearing, and the potential outcome. And one would understand that to be mediated partially by the child's interpretation of what their childhood was like. One of the great wise men of psychodynamic psychotherapy is a Englishman called Donald Winnicott, who treated kids in the war who were evacuated by the Blitz. He'd been a pediatrician before he was a child therapist, so he had a um, very broad sense of what normal was. He didn't pathologize kids because they sucked their thumb or something. Like he was very thoughtful, and saw a lot of kids who had degrees of trauma. And he memorably said, if there are 5 children in the family, there were 5 mothers, meaning that each child has their own individual experience of the parents. Even though the mom or the dad feels like they're doing pretty much the same thing, each child experiences it differently. Now, look at my gray hair. I got 3 daughters, I'll tell you, in their 30s now. And in my family, we can have these conversations. And I've heard them say, worse the effect of, yeah, but Dad. And one of them would go, forgive me, but they would say, fuck off, he wasn't like that. And it's completely clear they've had quite different experiences. And I'm sitting there thinking, I don't remember any of this. It was like a non-event for me, whatever this event was at that moment. So just to say that in personal experience, in psychotherapeutic history, and in the developmental psychological literature, there's a lot of support for the idea that children experience parenting very differently, sometimes for the better, and I'm afraid sometimes for the worse.
Thank you very much. All right, that wraps up our questions here. There are some comments in the chats just saying thank you for sharing your expertise and that they've had a wonderful time learning. I will direct everyone real quickly into the chat over there. There is a link I want you to check you out. Very cool, very fun, a survey for you to fill out and let us know your thoughts on this education session. We do take your anonymous feedback very seriously. So thank you for checking that out.
I'd love to get the feedback if you
Yes.
feel comfortable passing it on. It's helpful to us.
Yes, absolutely. Perfect. Thank you again so much, Dr. Hunter. It's
Okay.
been lovely having you. And
Have a good day, guys.
see you all later. Take care. Bye.